Good afternoon, everyone. Good afternoon. We'd like to get started. Let me first introduce myself. I'm Tanya Vidal-Kinlow. I'm the Vice President for Community Engagement, Advocacy, and Government Affairs. And I stand before you today to first thank you for joining us for the special Grand Rounds, but to also share with you just briefly about the community engagement operation here at Children's National, the Child Health Advocacy Institute. We are celebrating this week Community Health Improvement Week. We've had a series of activities that focus on the community engagement work that we are doing to help improve the health of our communities. And we are excited to be a part of this particular Grand Rounds because it shows a little bit how our community engagement work and the clinical environment are aligned. We've been doing a lot of outreach and activity with community leaders around serving all of our populations, but particularly special populations that need the support of not only our operations, but other government-focused entities, and I think that you'll learn more about that here in this Grand Rounds. But Desiree De La Torre, who is our Community Affairs Director, has led an effort that has resulted in a lot of focus around community work, and she will share with you more of that in just a few seconds. But I just encourage you to always think about how important it is to be engaged in advocacy on behalf of the people we serve. And your advocacy work is linked to anything that you're engaged in the community, in addition to the direct care that you're providing and services that you're providing, any community-related activities that you're engaged in. We're always excited to hear about it and want to know and hope that you will share with us in other activities that we have for you for Community Health Improvement Week. So thank you so much for giving us a little bit of your time.
Thank you so much, Tanya. Good afternoon. It's great to see so many great faces here at Special Grand Rounds, and thanks to those who are participating by WebEx. Thank you for joining us. We have two great speakers today. Kathy Gorman and Dr. Cohen will be joining us today. And how this relates to community health improvement is we're going to focus on a specific population that's coming into our emergency department that are having some challenges with drug abuse or substance abuse, and thinking about what are some of those upstream factors of what's in the environment that's causing some of these issues. And so that's what we think about when we do community health improvement. And so for this week, as we celebrate Community Health Improvement Week, please join us tomorrow at a poster session, a small poster session, not as big as Research and Education Week, but a smaller poster session that will feature some of our programs across the organization. That is from 1 to 3 tomorrow in the main atrium. There will also be an information table for how to get involved in a lot of the activities moving forward. Dr. Cohen will be speaking today, and she has an extensive background in research in emergency medicine and ultrasound. She did her residency at Johns Hopkins and did her fellowship at Children's National. She's here today to talk about the agitated patient. Thank you, Dr. Cohen, and thank you, Kathy.
Thank you, Tanya, and thank you, Desiree. Really appreciate that. Listen, what I wanted to do, good afternoon, and thank you all for being here. It is great to see so much interest in this really important topic. What I wanted to do is just kind of set the tone and the stage for what's happening in our community and what we're seeing here at Children's National in particular. And really, it was brought to light probably more over the last 9 months. Although Dr. Joshi sitting in the back has said it's been a growing problem for a while. And that's how do we manage this really complex patient population that is getting more aggressive, that is becoming more violent, and what we're actually seeing is some translated into what we call violence in the workplace. There are a couple of challenges here for us as we break down this population to say, what are we actually talking about? We're talking about the kids who are maybe perhaps on the MPD hold or forensics kids, the children that are primary substance abuse. So Dr. Newman challenged us to take a step back and say, how are we providing and delivering care in our hospital for these kids, and what do we need to do, to Desiree's important point around the community involvement. So there's been a lot that's happening, and I wanted to set the context and the tone for that. When you look at the background of the challenges we have, and special thanks to Linda, Tally, and Martha and Paul for pulling this data, when we look at the challenges we have in our own workforce or workplace here at Children's, we are seeing a number of reported violent events, meaning that either staff are getting harmed by patients or maybe by our families. And we're seeing a growing incidence of this. And we need specific strategies around how we're managing, how we're de-escalating, how we're making sure that we're providing the best care for our kids, and at the same time keeping you all safe on the front line. So we've taken this extremely seriously. And as you can see, as of April, we had actually reported of 19 events that had happened. We are not isolated in this. This is a national trend that's happening across the country. So if you look at violence in the workplace across the country, it is a huge challenge for many hospitals that we're seeing this increase. In addition to that, I wanted to back up and say some of these patients may have a diagnosis of mental health. Some of them may have a diagnosis of substance abuse. But what we are seeing is this growing trend. And we're seeing this is data that Dr. Chamberlain provided and Dr. Joshi as well, in terms of looking at the growing number of our psychiatric patients that we're seeing in our very, very small ED that can manage them. We have 4 psychiatric beds. We're seeing a huge growth in this. And now we're seeing a patient population that is really unique and requires real special attention and advocacy on our behalf to address these growing trends. At the same time, what Dr. Joshi and Jim Chamberlain, Dr. Chamberlain and Teresa are managing, they're managing along with our security department, the length of stay is going up for these patients as well, meaning we're having a harder challenge and time with placing these patients back into the community or finding an appropriate place for them. So these are some of the challenges ahead that we're dealing with. We're also seeing a number of patients that are having to be boarded because there's not appropriate facilities in our community to take care of these, and they're being boarded in our emergency department. This requires a whole new level of staffing. It requires a whole new level of management. It really requires, as we take a step back, a whole look at our facility and how are we going to be able to care for these kids. But we're not in isolation again. This is a trend across the city and across the country. And to Tanya's earlier point, we have had many wonderful, wonderful meetings with community partners on how we're going to be managing this. We've also seen a growing increase with this, with MPD, Metropolitan Police Department holds. And one of our colleagues is here in the back row. Thank you very much for coming and joining us. We appreciate it. One of Chief Lanier's team members is here. So we're seeing a growing number of Metropolitan Police case holds, which means that we're seeing a greater presence and there's more activity that's going on in the community. And they are keenly aware of this growing trend as well. So just to take a quick step back, what are we doing? We have a whole strategy around this. We have an internal strategy and an external strategy. The internal strategy is being led by Linda, Dr. Shaw, Martha Para, Dr. Joshi, and many others are involved in this work. We're looking very specifically at our facilities and making sure our facilities are safe. We're looking at the care model and the staffing and how do we staff for this new emerging population that we're seeing, both either in the substance abuse population, thank you, or in this growing, more aggressive psychiatric population, or they may not even have a psychiatric diagnosis. And we're also looking at education and training. Thus, the rollout of this 2-part series, specifically addressing this population, with this first series being today around learning more about the substance abuse population that Dr. Cohen's going to share with us. And then next week, or actually in 2 weeks, we're going to hear from Dr. Joshi around how do we manage this new kind of emerging population. From an external standpoint, many of us have been involved, Tanya Kinlow and her team, myself, Dr. Denise Kaur-Bramble, Dr. Joshi, looking at how can we partner differently with our community. And we met with Dr. Royster, who's head of the Department of Mental Health. We've met with Chief Lanier and her team. We have met with Deputy Mayor Donald to share as well, and Dr. Nesbitt, who is over the Department of Health. There is a huge interest and support from the city for us to solve the challenges that we have around this population. So again, we're not in isolation. So we're working on the citywide collaboration. We're working on access issues around how we manage that, and identification of any citywide gaps as well, where we can be part of the solution to some of these challenges, and just make sure that we're always advocating for these kids. So at this point, I wanted to share that with you. I'm going to turn it over to Dr. Cohen, who's going to go into a very interesting grand rounds on management of the child with substance abuse.
Thank you. Switching the WebEx.
I just want to let you know that the clicker isn't going to work for your laptop.
Oh, okay, no problem. Great. Okay, great. Thank you. Okay, thank you for having me here today. Again, my name is Joanna Cohen. I'm joining you from the Division of Emergency Medicine, and we're talking here today about the adolescent patient who presents agitated and intoxicated, and this is something that we have a lot of familiarity with downstairs in the emergency room. So I thought I would start, or not. Okay, I thought I would start with a case. This is kind of our typical case. It's a 14-year-old male who has no prior medical or psychiatric history, who's brought in by EMS for what's diagnosed as behavioral changes. And this child had been out with some friends, and he came home, and his parents noticed that he was agitated. They called EMS, and when he arrived in the ER, he's noted to be uncooperative and agitated. He's tachycardic, he's hypertensive, the rest of his vital signs are normal, but he's difficult to examine because he's really combative. And what we're going to address here today is how are we going to approach this patient. So the differential diagnosis of the differential diagnosis of a patient who comes in with altered mental status or agitation is really broad. There are medical causes like hypoxia or metabolic problems like hypoglycemia or hyperammonemia. They may have unwitnessed head trauma or infections like encephalitis. It could be a new presentation of a psychiatric disease, but what we're going to focus on today is toxicity. I do want to mention the environment that the patient is in, because when we talk about agitation, the environment is really an additive effect. And I wanted to share this photo with you. This is Coney Island ED after Hurricane Sandy. It's from the New York Daily News. And what you can see is that it's really chaotic. It's an unstructured environment. It's probably very loud in there. It's unfamiliar to the patients. There may be spotty access to food or drink. And these are patients who are already under stress, right? They've just experienced a hurricane. Maybe they've lost family, maybe they've had property destruction, maybe they don't know where their children are. So they're already stressed, and then you put them in this very chaotic environment, and it's not the ideal situation for de-escalation. And it's similar to what happens downstairs on a daily basis, where it's very fast-paced, it's very busy, and we really have a limited amount of time to address the range of behavioral concerns that come in. And so sometimes these patients end up getting admitted to the floor or sent to another unit like radiology before they've been de-escalated. And then the staff on that floor or in that unit is really dealing with this patient. So I think it's important for all of us to be aware of how to deal with it. So by the end of this talk, I'd like everybody to be able to describe the changing landscape of illicit drug use and to recognize the stages of agitation and have some idea of how to manage agitation in the acute care setting. So what is agitation? So it's an unpleasant state of extreme arousal. And in the medical literature, you'll see agitation defined as a state of behavioral discontrol that will likely result in harm to the patient or healthcare worker without intervention. And for our purposes here today, I really like this definition as we move forward. So So what's the scope of the problem? So in the U.S., there are 30 million pediatric ED visits annually, and about 3 or 4% of those are for behavioral problems or agitation. Half of those are going to have a previous psychiatric diagnosis that's likely causing the agitation. So if you do the math, you're left with 600,000 pediatric ED visits in the U.S. for patients who are agitated who are not psychiatric patients. And about 20% of those are going to require some crisis intervention, meaning either physical or chemical restraint. Adolescents and males are at higher risk for agitation. Patients who have fewer friends are at risk for agitation. They have more risky behaviors like substance abuse and more involvement with the law, and also higher rates of depression. And it's important for us to note that there's this connection between aggression and impulsivity and suicide-related behaviors. It can be harder to detect depression and suicidality in patients with aggression, ADHD, and high impulsivity, but it's something that we need to be aware of so that when we do put these patients in isolation or we put them in a room, we make sure that we create a safe environment for them where they can't injure themselves. So approximately 10% of adolescents meet criteria for substance abuse or adolescence, according to the literature, but this number is actually probably higher. And some common substances that adolescents use are alcohol, anticholinergic drugs, sympathomimetics, hallucinogens, cannabis, and this group of newer synthetic drugs, which includes synthetic marijuana, synthetic stimulants, and synthetic hallucinogens. An in-depth discussion of all of these drugs is beyond the scope of this talk, but I'm going to give a quick overview of some of them, and then we're going to talk more in depth about some of the newer synthetic drugs, which you may be less familiar with. So alcohol is really the drug of choice for adolescents. This is from the 2005 Monitoring the Future study. It's an annual survey of U.S. youth, and they found that 3/4 of 12th graders, more than 2/3 of 10th graders, and 2/5 of 8th graders have consumed alcohol, like at some point. But when they drink, they tend to drink excessively. This chart shows that 11% of 8th graders, 22% of 10th graders, and 29% of 12th graders had engaged in binge drinking, and what they mean by that is more than 5 drinks in one sitting in the 2 weeks before the survey. Like really kind of impressive. It's scary, but it's astounding, yeah. So children who drink early, before the age of 12, tend to share a similar group of personality characteristics that may make them more likely to start drinking. And these characteristics include disruptive and hyperactive and aggressive behaviors. They're also more likely to be depressed and withdrawn or anxious. They may have other behavior problems associated with alcohol use in younger adolescents and put themselves in positions where they can become harmed or cause harm to someone. They tend to have a disregard for rules and poor impulse control. And what you can see is that many of these traits are similar to the risk factors for aggressive behavior. And the bottom line is that these really tend to be the same population of kids, the kids who get aggressive and the kids who are likely to start using alcohol early. Anticholinergic drugs, the most common anticholinergic drug that we see in the ER here is diphenhydramine or just Benadryl, and I think that's just because they have very easy access to it. Scopolamine you may see in other areas. Jimson weed, which looks like this, is found more in rural areas. There's been a lot of reports in areas like West Virginia. It tends to grow on the side of the highway, and usually the leaves are like smoked or brewed in a tea. And if you remember from way back when, patients who have anticholinergic toxicity present hot as a hare, dry as a bone, blind as a bat, red as a beet, and mad as a hatter. And people used to use physiostigmine to treat this, but we really don't do that anymore because there's this potential for cardiopulmonary arrest, which is way worse than just being aggravated. So we have other things that we use now, and I'll get to that a little later. Sympathomimetics include Sudafed or pseudoephedrine, which is really easy for the kids to get. Amphetamines like Adderall or Ritalin, which a lot of kids have access to because either themselves or their friends are being treated for ADHD. And MDMA, which is ecstasy or methylene dioxymethamphetamine, also called Molly, which is short for molecular cocaine, and methamphetamine. And the sympathomimetic toxidrome, the patients are tachycardic, hypertensive, tachypnic, they have dilated pupils, high temperatures, they're sweating, they often have goosebumps, they can have seizures, delusions, paranoia. And then the hallucinogens. The hallucinogens include PCP, ketamine, LSD, dextromethorphan. And at high doses, dextromethorphan acts as an NMDA receptor antagonist, which is similar to ketamine or PCP. And this is found in Robitussin and Triaminic and all these over-the-counter cough syrups. And adolescents are really the highest users of dextromethorphan because it's very easy to access the drug. And it will create this dissociative hallucination just like ketamine, PCP, or LSD if you take enough of it. Cannabinoids, marijuana is the most commonly used drug in the U.S. secondary to alcohol. The THC activates the cannabinoid receptor in the CNS, and it can cause anxiety or panic. Patients who have inhaled or ingested natural cannabinoids are rarely combative, and this is really different than the synthetic cannabinoids, but we rarely have patients who've smoked natural marijuana who get combative. They're more catatonic. So synthetic drugs. So we're going to focus a little bit more on the synthetic drugs. So the synthetic drugs or the designer drugs are actually versions of illegal drugs that are chemically altered just slightly to avoid having them be classified as illegal. And then as law enforcement starts to catch up and they're made illegal, the manufacturers alter them again just a little bit, and the cycle keeps repeating itself. And so in the U.S., there were 200 to 300 new designer drugs that were identified between 2009 and 2014. There are more than 600 in Europe in the past 10 years, and most of these are manufactured now in China or India, and then they're routed through Europe, and that's how they get here. Synthetic cannabinoids, this is our biggest problem here for the synthetic drugs. It's also called, most common names we hear are spice or K2. It's a variety of synthetic THC analog chemical with a higher binding affinity for the cannabinoid receptor. It's usually made in a lab. A lot of literature talks about how it was first made in Clemson in the 1980s in Clemson University for research purposes, but it's actually made much earlier than that in Europe. But now, again, made mostly in China and India. And what they do is they mix it with acetone and they spray it on a plant so that it looks like marijuana, but the spraying can be really uneven, so the potency can really vary widely. It can't be detected on our standard drug screen, but it can be detected in the urine, and the Department of Health has been working on creating a drug screen, and they've asked us to give them samples. According to them, the most common age that they're getting samples from is about 38 years old. They're getting much fewer samples from us, and I don't know if this is a factor of us not doing a good job of streamlining the process of us getting them samples, or if we're actually seeing a lot lower numbers than they're seeing in the adult patients. And it's probably a combination of those two things. But there's this concern that it may be more toxic and more addictive than naturally occurring cannabinoids. So synthetic cannabinoids, it looks like marijuana but feels like LSD. So I've heard, I've never tried it, but that's the word on the street. It can cause tachycardia, hypertension, which can be very severe and lead to seizures, MIs, stroke, kidney injuries. Patients report a lot of anxiety, disorientation, hallucinations, paranoia. Patients often report like seeing monsters and demons and aliens. And they can have suicidal thoughts or actions. Synthetic marijuana has a ton of street names, and so I strongly suggest that when a patient reports to you or to EMS that they took something and you have no idea what they're saying, look it up and either Google it or look in the Urban Dictionary, which is like a wonderful resource for this stuff. But there really are this is like a little snippet of the number of names they have for synthetic marijuana. So how big is this problem? Well, in July of 2015, we saw a sharp increase in synthetic cannabinoids in D.C. This is from D.C. Fire and EMS. This was in the Washington Post. Prior to July 2015, there were about 15 EMS calls involving synthetic cannabinoids per day. But in the summer of 2015, we saw an 8-fold increase in those numbers from 2014. Police and EMS report increasing violence and overdose. In September of 2015, DC Fire and EMS workers responded to 611 phone calls concerning synthetic drug overdose. For context, during that same period of time, they responded to 591 calls regarding car accidents, 61 for stroke, 58 for heart attack, and 32 for stabbing. So this is really, you guys are busy back there. The American Association of Poison Control determined that the district ranked second in the country with regard to synthetic cannabinoid exposure, trailing only Mississippi. I know, right? Okay. And Mississippi, right? At least, like, we're near a port. Like, it makes sense. I don't know. Maryland and Virginia also ranked in the top 10. So we're really like a central hub for this stuff. In September 2015, this is also from the Washington Post, DC police seized $2.3 million worth of synthetic drugs that were stored in a warehouse in Northwest DC. Included 19,000 packets of a strawberry-flavored drug that was labeled Bizarro, and the total weight of the drugs was 265 pounds. Okay, so it's a pretty substantial new source of psychosis for us here in DC, and this is really our biggest problem. This is much different than when we talk about the other synthetic drugs, like bath salts. So synthetic cathinones, or bath salts, are a chemical version of cathinone, which is a stimulant that comes from the cat plant. The cat plant is from Africa and the Mideast mainly. It's traditionally chewed for its stimulant effect. It was manufactured in France initially in the 1920s, and then it was used as an antidepressant in the former Soviet Union in the 1930s and 40s. And then it started gaining popularity in the US in the 1990s. And in Netherlands, they found in 2009, they seized a bunch of what was supposed to be ecstasy pills, and they found that over half of them were actually bath salts. So this is kind of known as a cheap substitute for MDMA or Molly. The synthetic version is distributed in a similar fashion to synthetic cannabinoids, where the chemical is made in a lab, and it's packaged under different labels like jewelry cleaner or iPhone cleaner, plant food. And it can either be found in a powder or a small plastic or foil containers, or it could be a liquid in a jar, depending on how it's labeled. And it can be inhaled, injected, or what they call bombing, which is when they wrap the drug in cigarette paper and just swallow it whole. Yeah, and it creates hallucinations, hyperactivity, paranoia, and I don't know if anybody's been reading about, you know, these kind of drugs in the newspaper, but this is where they report about, like, the zombies. Have you seen that, where, you know, people are eating other people's faces? That's BAFTA that does that. Yes, Jason Woods isn't here, but that was really for him. So there are just as many street names for synthetic cathinones as there are for synthetic marijuana, if not more. But it's much less prevalent in this area, and when you look at the poison control reports, it's only a few a year. So this is much less of an issue for us here as synthetic cannabinoids, but we have to keep an eye on it because we don't know how these prevalences will change over time. There are also synthetic hallucinogens known as N-bomb. Most commonly, it's sold as an alternative to LSD or mescaline, which is a drug that's made from a cactus plant. It was manufactured in Germany in 2003, and it's now made, again, mainly in China and India. And this drug, it comes as a liquid or powder, and then it can be, like, soaked onto a blotting paper that the kids can put on their tongue, and then it kind of gets absorbed through the tongue. And it's a real problem for law enforcement because it's so concentrated on that paper that if they find it and they touch it, and they touch like a certain amount of quantity, a significant quantity of it, it can go transdermal and cause an overdose for law enforcement. So they need to be really careful when handling this stuff. And this goes by other names like 25I, 25C, 25B, Smiles, and legal acid. And there are a few other drugs that you might see in the DC area, mainly methamphetamines, but also Salvia divinorum, which comes from the cloud forest in Mexico and has been like widely publicized in Delaware because they had a case of a child who committed suicide while using this drug. But we see them much less in this area than the other drugs that we just talked about, so I'm really going to kind of shelve them as beyond the scope of this talk today, and we're going to turn our attention now to how we're going to deal with these patients when they come in. So what next? So we may have a better sense of what's aggravating our patient, but it doesn't make the situation any less threatening for our staff or the patient. And so how are we going to approach this patient? So the management of aggression really requires a pre-planned systemic approach. We need to have clinical pathways in place. We should have response teams. And the goal should really be staff and patient safety first. The secondary goal is therapeutic treatment for our patient, and our last goal is to prevent the patient from absconding, and that's really the third priority. The response is going to depend in part on the location of the incident. About half of these incidents occur in the ED, but they can also occur in the wards, in the clinics, in the ORs, or even the staircases and the hallways and the cafeterias. So we need to have an institution-wide approach on how we're going to deal with this. Most incidents occur after hours, and so who is available at the time is going to determine who the members of the team are. Likely the clinical staff will be involved, the doctors, the nurses, and the techs, but also the security officers. And if the aggressor is a visitor, sometimes hospital administration will be involved. And what the team really needs to recognize is that these events happen in a somewhat predictable manner. So the first step is usually verbal threats and abusive language. So for the nursing staff here, how many of you have experienced any sort of verbal abuse in your job? Okay, good, right? So it's amazing. It's estimated that 85% of nurses have experienced verbal abuse, and that's not good, okay? So if that progresses, the next step is constant moving. Usually the patient starts to fidget or pace, or they may tap their foot when you see some sort of repetitive movement. And if they progress beyond that, then they get property damage and destruction. And the last phase of aggression is attacking themselves, causing injury to themselves or to others, and attacking people. And rarely patients go from 0 to 60. Most often they follow this pathway, but we have had patients go 0 to 60 before, where they verbal and then all of a sudden they're attacking you. And I think these people are just totally unpredictable, and security should be there immediately, and they just need to be removed. And the management, the response is also going to depend on the management is also going to progress in a stepwise fashion. So the first thing you're going to do is provide verbal and calming interventions and space modifications, and then chemical or physical restraints. And then the last step is really if the patient needs to be escorted out by security or transferred to another healthcare facility. If the aggressor is a parent or visitor, typically we skip from step 1 to step 3. So if the patient gets a little aggressive verbally or is abusive verbally to patients or to staff and is cursing or using foul language, and we try to verbally de-escalate them and they are not calming down, that is a time for security to remove the family from the situation. If it's a patient that we're taking care of, we can do some chemical and physical restraint. So if you can figure out what the cause of agitation is and address it, that can be really helpful. But patients who are agitated can escalate quickly, and sometimes we need to treat them without knowing what the cause of agitation is. The first thing we want to do is remove any family members or staff that's causing conflict. And it may be just that they're screaming and yelling that, that they don't like their nurse. Well, let's try to give them a new nursing assignment. Let's see what we can do to de-escalate the situation. We also want to minimize noise and light, and we want to offer food, beverage, and warmth. It's amazing how far food will go, and sometimes I wonder if these patients are just hangry. But we do want to feed them. And then we can also use distractions. So we do have some iPads and things like that we can give them to see if we can get them to start playing a game, or maybe they can get involved in something else. And while you're doing these things, you want to stay 3 or 4 feet back from the patient for your own safety. If these things aren't working, your next step is going to be physical or chemical restraint. Physical restraints are really anything that restricts movement of the patient, and this includes belts, car seats, it could be papoose, vests, high chairs, handcuffs, really locks on doors, alarms, removing keys. Anything that restricts the movement of a patient is considered a restraint. We don't do that, but we should. No, just kidding. So physical restraints should really only be used for patients who are a danger to themselves or others. There needs to be clear indications. They're not to be used for punishment. And the AAP recommends that there are clear reassessment guidelines and safe application. And that means that the device should not be put on the patient if it's going to put them at risk for medical decompensation. So the first step in applying restraints is to explain to the child and family why the restraints are necessary. And often this is something like, so they don't pull out their IV, you know, just something like to move forward with their therapeutic care. And you want to give them an opportunity for verbal de-escalation. And then you're going to need a physician written or verbal order that has to indicate the type of restraint, the indication for restraint, the estimated duration of the restraint, and it needs a regular review and renewal of the order, which must include documentation that the restraint was placed appropriately and evaluates the skin integrity and the neurovascular status of the patient. And you have to document the continued need for physical restraint. So some of the common types of restraints that we use here, we use 2-point restraints, which would be a contralateral arm and leg, 4-point restraints with one arm up and one arm down. The restraints can be soft or they can be leather, and we can use papooses or posy jackets, which we don't use in the ER, but I imagine that they use in other units in the hospital. The Joint Commission categorizes the use of restraints as a special treatment procedure and requires special justification for their use. The standards require that the hospital policy address the periodic observation of patients for whom restraints are used. So here at Children's, we have to renew the order hourly for patients who are less than 9 years old, every 2 hours for patients 9 to 17 years old, and every 4 hours for adolescent patients or adults who are over 18. Restraints are not without complications. The most common complications we see are minor trauma like abrasions or bruising or pressure sores. But if the patient is very agitated, you can have metabolic complications like hyperthermia, increased sympathetic tone, even lactic acidosis or rhabdomyolysis. If the patient has been placed supine, there are reports of them aspirating or placed prone, they may asphyxiate. And death from restraints is extremely rare. In a survey, a 10-year survey in the 1990s, there were 142 deaths attributed to restraints, and 33 of those were pediatrics. So it's not without risk, but death is rare. And there is much less risk associated with chemical restraint, which I think people don't necessarily realize. So chemical sedation or chemical restraints, really the goal of chemical sedation is rapid tranquilization. You always want to offer collaborative, voluntary oral sedation first, and oftentimes patients want to calm down and they will accept that. But involuntary IV or IM sedation is an option for many patients. And you can use physical restraints temporarily while titrating chemical sedation. The main pharmacological drugs that we use for restraint include benzodiazepines, antipsychotic drugs, either the typical or the atypical type, diphenhydramine or Benadryl, ketamine, and then combinations of drugs. Benzodiazepines like Ativan and Versed facilitate GABA transmission. The onset is very quick, 5 to 10 minutes if it's given IM or IV. It can help with alcohol withdrawal, but you really want to use it in caution in the patients who are intoxicated with alcohol because it can give them this oversedation. There's this risk of oversedation. It has anticonvulsant properties, which can be very helpful in patients with very high blood pressures or patients who've used cocaine or other sympathomimetics recently. There have been reports of paradoxical reactions, and the main risks are hypotension or respiratory depression. The next thing we're going to talk about are the first-generation antipsychotics or neuroleptics. This includes Haldol or haloperidol and chlorpromazine. Haldol is the most widely used and studied. We have the most experience with it. We use it fairly commonly downstairs. The dose is 0.025 to 0.075 milligrams per kilo per dose, which is usually somewhere between 2 and 10 milligrams typically. Chlorpromazine is an alternative, but it's not as effective as Haldol in comparative doses, and it has anticholinergic effects, so it's not a great choice for patients who've ingested TCAs or over-the-counter hypnotics or herbal hallucinogens. The onset of action is 20 to 30 minutes IV or IM, and you can get extrapyramidal symptoms like dystonia, akathisia, Parkinson-like effects, or oculogyric crisis, which is a spasm of the extraocular movements where it looks like the children are staring upward. And then there are some life-threatening signs like neuroleptic malignant syndrome, which is really, really rare, laryngospasm, and the patients can get QTC prolongation, which can lead to cardiac arrhythmias, particularly in patients who have underlying prolonged QTCs. The atypical antipsychotics, or the second generation antipsychotics, include Risperdal, Zyprexa, Seroquel, Geodon, Abilify. They inhibit the serotonergic and the dopaminergic transmission in the brain, and they can also cause extrapyramidal symptoms and neuroleptic malignant syndrome, QTC prolongation, but to a much lesser degree than the typical antipsychotics. The data in emergencies, in agitation emergencies for patients who do not have underlying psychiatric diagnosis is really limited, so we tend to not use these drugs in patients who don't have an underlying psychiatric diagnosis. Benadryl or diphenhydramine can be used as a single agent for less severely agitated patients. It antagonizes the H1 receptors. It does have anticholinergic properties, so it's best not to use this in patients with suspected anticholinergic toxicity. It's very well tolerated, but can cause a paradoxical disinhibition in some patients, which is not fun. Ketamine, this is widely used in the adult ED setting. The dose that they use for sedation is 2 to 3 milligrams per kilo or 200 to 300 milligrams IM for adult-sized patients. The median onset of action is 20 minutes, and there's a very wide safety margin. It rarely causes respiratory depression. And it's dissociative, so it's not a good choice for patients who are already hallucinating. And these are ketamine darts. This is what they use like in the wild or in the zoo to take down animals, not so far from what we do downstairs. But I just want to point out that median onset of action is 20 minutes. So when people are thinking about the little boy in the gorilla cage, like this is why, it takes too long to take this patient, to take the gorilla down. So then there are combinations of drugs that we use typically. So the most common combination that we use in the ER is Haldol and Ativan, which works really nicely. They're synergistic. They're compatible in the same syringe. And so the Ativan takes effect first, and then the Haldol kind of holds them over for a much longer period of time. Does anybody know who these guys are? Oh, I'm so glad you got that. Okay. That would be B52s. Okay. So you may hear in the adult ER people saying, like, give them a B52. That's 50 of Benadryl, 5 of Haldol, and 2 of Ativan. But the B52s were actually named for the fighter plane, not the drug, because their hairdo looked like the front of the plane. But anyway. So I just wanted to make one more comment about the armed aggressor. So there really is no clinical approach to the armed aggressor. This should really be a security and police response only. There are 154 hospital shootings between 2000 and 2011 across 40 states, and 30% of those occur in the ER. And that's a really low number. So you're like less likely to be shot in the hospital than you are to be struck by lightning. But it's something we need to be aware of, and something we should not like approach that patient or attempt to like offer them drugs. We just call police and security and get the situation under control. So just some take-home points. The use of synthetic cannabinoids are on the rise in our area. We need to be aware of the stages of agitation and consider our management options. We always want to start with de-escalation, and then we can progress to physical and chemical restraint. I'll take any questions, comments, or concerns.
And here are some.
Here's a list of references. If anybody's interested, I could email those out.
Great. Thank you very much. This was really wonderful. I appreciate it. Kind of a comment and a question, actually. I think one of the things that we've really been thinking a lot about is the impact of early trauma and adversity on children and adolescents, and how it, I think it's pretty well documented that children and adolescents exposed to this have higher rates of substance abuse, but also higher rates of activation and higher likelihood of becoming agitated. So that's kind of my comment. My question is, SAMHSA has described a pretty well documented approach to institutional training and care called a trauma-informed approach to care, where you sort of infuse these principles throughout training across an organization. And so I'm wondering if that's something you all have thought about as a way of, I mean, it really infuses these principles from every level of staff training, of sort of recognizing what the signs of a history of trauma in an individual may be and how that may contribute to their activation. So I'm wondering if that's something you all have thought about at all.
All right. Yeah, let me grab a mic. Thank you, Lee, for that good question, and then I'll give it back to you. Thank you, Lee, for that great question. And so what we are doing is we're starting a series of education. I don't think we've thought about the formal training of the SAMHSA at this point, but we certainly can include it. I also wanted to comment on a couple things. Excellent, excellent job, Dr. Cohen. Thank you. Thank you. Comment on a couple things we're doing across the house. One is we are looking at the behavioral management response team. So Linda and Martha and others are leading that with Dr. Shaw as well around how do we respond if we have these situations that come up in the ED, in the stairwell, in the cafeteria, on one of the patient units, and what is our response. So we're working on that now, and I think we'll be piloting that in the very near future. There's also some other training that we're partnering with PIW. So PIW is Psychiatric Institute of Washington, and Dr. Joshi and I reached out to them, and they do some very specific de-escalation training with their staff. They actually don't have security on staff, so Paul would be, it's interesting. So their security does not necessarily respond to their events, but their staff know how to de-escalate an event. So we're going to be rolling that out as well. But it appears to me we now have probably a third series in our grand rounds to hear from Dr. Beers around the toxic stress and some of the challenges that are in our community around the precursors to this. Because this, what we saw with Dr. Cohen's presentation, the data that we're experiencing, or the increase in volumes that we're experiencing, just doesn't happen overnight. There are reasons for it. So I think we'll be tapping into you for your expertise. Great.
I was just going to say another option for IM, of course, would be droperidol, which is quicker onset and not as much dystonia, but still the issue of torsade de pointe. And there are some sublingual antipsychotics that are fairly sedating and FDA approved in adolescent use, like acenapine, which really makes people very drowsy, and I would imagine that's one of your goals when somebody's really agitated and acting out without having to hold them down and give them a shot. So there are other options psychopharmacologically.
And that is, so our team is working with your teams as well through Dr. Joshi on those cocktails, so to speak, and what can be administered. Dr. Steinhorn has been involved in those conversations because once we do administer something on the floor, we have to determine what's the appropriate monitoring, if it's on the floor or if it's in the emergency department, and how do we make sure that we keep that patient safe, which would be different from what we do right now in terms of administering those kind of meds on the floor. So we're looking at that. So your partnership is great with Dr. Joshi on that. Thanks. I want to recognize our visitor here from the MPD. If you want to, I don't mean to put you on the spot, but really want to thank Chief Lanier for having you come today, and I'll let you introduce yourself.
Hi, I'm Lieutenant David Augustine. I work actually with Chief Lanier down at headquarters. We've been asked a few weeks ago. We actually met with the staff up here, and we were very grateful to be invited back. This is a very big topic. Some of you might have seen Chief Lanier actually testified in Capitol Hill about synthetics yesterday. We met some wonderful people. We even, some of the rural issues were very common of what they're seeing in the city. So this is a nationwide issue that we're trying to attack, and we look for everybody's input so we can make everybody safer out there.
And thank you. We've been in constant correspondence, Lieutenant Augustine and I, around setting up a town hall with the chief and her staff and frontline members, because one of the things that came out in the meeting that Dr. Newman hosted with Chief Lanier was around the big challenges. And when she actually said, you know, we learn the most from our frontline staff. So we want to hear what the trends are in the community, what's happening in the emergency department, what's happening as we learn in our psychiatric units on our medical floors on some of those trends, so that they can help keep our community safer. So we really want to thank you for that partnership. You guys are doing a fantastic job, and we just heard some of your trends earlier with what the challenges you're dealing with. So thank you. It is scary. Other questions?
I just wanted to say a thank you to our security staff in the ER. Since they've changed over, we've really had a significant decrease in the number of violent events that we have. Having their presence in the front door is really important to us, and they've really been excellent. So we appreciate them.
Any other questions for Dr. Cohen around the clinical content, or for any, for Linda Talley, for Martha, for myself, or Dr. Shaw around some of the system-wide improvements that we're working on, or the community partnerships that we're working on with government and community relations with Tanya? Any questions? Another question.
Just a quick question about whether or not we see any kind of incidences happening within the community clinics.
Is there, I don't know, any trends or
The microphone we
Yeah, I work in the hospital-based clinic. I know in the hospital-based clinic, we do occasionally have these situations occur. Actually, Chris and I were just talking about it, similarly to what you said. We've actually noticed over the past 6 months actually a great decrease in that, and a real emphasis on de-escalation, which has been really important. So we do still see some of the same things, not quite as activated. I don't know for sure about our satellite community clinics. They do have security presence at those clinics, but I'm not 100% sure where they stand in terms of how often they need to invoke their presence.
And we haven't seen anything in our safety data per se, right, Dr. Shaw, that has shown up around that, but it's a great question, and certainly, I think as Dr. Cohen pointed out, can happen anywhere we see patients. So great question. Any other questions, comments? Okay, well, this is part one of a part now 3 series, putting Dr. Beers on the spot for education. So anyway, we're going to continue this, what we'll call as our summer educational series, and we just to thank you for your participation. This was just outstanding. Thank you, Dr. Cohen, and this work continues, and we need everybody to work together, so thank you so much.